Hello, everybody, and welcome to our second installment of Burning Migraine Questions. It's a little kind of Facebook Live event, interactive session that we hope to do 1 to 2 times per month, depending on interest. We had a sort of a soft opening with our initial episode, if you will, and so we hope to have as many people join us this time. We already have had a number of people submit questions ahead of time, and so hopefully these same people will be joining us live today. As always, you can join us by clicking on the links on the Peled Migraine Surgery Facebook page or following the URL on the various social media platforms where this event is posted. I'm going to start off with a question that's already been submitted, and is a question that I get quite often, and that is that this person named Lisa wants to know, all my imaging studies have been negative. I've had an MRI, in this case of the brain and the cervical spine, that's the spine and the neck, but they don't show anything. How is it that I have this neurologic condition? And I think there's a couple of issues with regard to that question that need to be answered on several levels. First of all, it depends on what it is that you're trying to study or image, because, for example, if you said, I have diabetes and I want to do an MRI of the cervical spine or brain to decide if I have diabetes, of course, that might sound silly because diabetes is a chemical abnormality within the blood, and you won't see those changes with blood sugar on an MRI. That's just not how you test for diabetes. In a similar sense, the MRIs of the cervical spine or the brain are typically meant to look for very specific things. So, for example, in the brain, you might be looking for a stroke, a brain tumor, plaques consistent with Alzheimer's disease or multiple sclerosis. In the cervical spine, you may be looking for things like herniated discs, pinched nerve roots, which are very, very large nerves that can be easily imaged on the MRI technologies that are present in most places, or a fractured vertebrae or severe arthritis within the cervical spine. However, if you're looking for very, very, very tiny nerves, like the third occipital or lesser occipital nerves, these are very, very poorly, if at all, imaged on an MRI or your standard MRI. And there are various strengths of MRIs. Most people, when they get an MRI, they have something known as a 1.5 Tesla MRI. The higher resolution MRIs are 3 Tesla MRIs. And there are even a few places where there are experimental machines going as far as 4.5 or 9 Tesla. But these high-resolution imaging modalities are not widely available. And it is unclear whether or not the imaging resolution in these newer, stronger machines will be capable of imaging nerves that are a couple of hairbreadths thick. I think that's going to be very hard to do. Along with that, there is the issue of a saying that I'm reminded of from one of my mentors at Harvard, who used to say, Zeev, you have to be able to see what you're looking at. So in other words, your ability to detect any sort of pathology on an MRI depends not on just having the test, but on having it done accurately. Fortunately, most places do plenty of MRIs of the cervical spine or brain, and so the protocols for imaging those studies in terms of the standard things you're looking for, such as brain tumors and herniated discs, are pretty well established. But you then have to have a radiologist who is expert at reading and evaluating for that particular pathology. So if you have a radiologist whose specialty is in reading musculoskeletal imaging studies, such as looking for a torn ACL, if that person is also now looking for a subtle finding of a brain tumor or a swollen nerve, they might miss that finding, and the study may be read as negative, which does not necessarily mean it's negative. So I think it's very often the case that people who come to see me and have failed more conservative modalities have negative imaging studies for several reasons. One, the technology that's being used is too low resolution to actually image the nerves, which are not very adequately imaged with standard MRI technology. That's number one. Number two, oftentimes what you need if you're going to even have a prayer at finding some inflammation in these nerves is what's called an MR neurogram, which is a special MRI piece of software that not everybody has that highlights the nerves. So that has to be put into place. And then you have to have a radiologist that knows exactly which nerves you're looking for and what the problem is. And so if you have a doctor who orders an MRI of the cervical spine and just says this person has headaches or neck pain, that radiologist is likely to be looking for brain tumors or herniated discs instead of small pinched peripheral nerves, and therefore the study is likely to be read as negative. Let's see. People often ask, what is the recovery time and process for cleaning up certain nerves versus other nerves? So for example, the greater versus the lesser, the third. The answer to that is a very general question, and it depends on a number of factors. Your ability to recover from an operation on a nerve in the head and neck depends on how many nerves you operate on, which nerves those are, and other comorbidities that you have. So for example, if you're an older person with a bad heart and bad lungs, maybe you're on steroids because you've got severe asthma or rheumatoid arthritis, your healing time will be a lot longer than a young 26-year-old who is otherwise completely healthy. And then, of course, it also depends on what it is that you're doing with that nerve. So, for example, if you have a nerve that you're just decompressing and you're doing that to one nerve, your recovery time is going to be a lot less because there's only one nerve that's being manipulated. There's only one nerve that has to be dissected out. Whereas if you're doing a similar procedure on 6 nerves, but in that case, you're cutting several of them and implanting them in the muscle, what has to happen in those cases is those nerves have to heal and settle down in the muscle. And so in terms of recovery time, meaning decreased pain and settling down those nerves, that may take longer than a nerve that was relatively minimally compressed and only was decompressed as opposed to transected and implanted in the muscle. We have another person here that's asking about the statistics of success rates for the surgical procedures that I've done. So let me start out with the general information that's out there. This data was actually published by Baum and Gayaran, who is the person who first started doing these operations many years ago, almost 20 years ago now. The 5-year results for these types of operations was actually published back in February 2011. So this data is not new by any stretch of the imagination. And it showed in that paper that when all of the trigger points are adequately decompressed, so in other words, you may have problems in the back and the front, and this type of data would only apply to those people who ultimately have decompression and or excision surgery, transection surgery in the back and the front. But once all of the trigger zones were adequately addressed, 88% of people 5 years after surgery were still experiencing a minimum 50% or more reduction in the frequency, severity, and or duration of their headaches. And 29% of those patients were migraine free. Now, specifically with regard to my experience, my numbers very closely match those. I presented my results for my first 100 patients several years ago at the California Society of Plastic Surgeons meeting. It actually won the Best Paper Award that year. And the follow-up at that time was a little over a year and a half. So many of those people had been out several years at that point. And my numbers were very similar. About 87 or 86% of patients were experiencing a minimum 50% reduction in frequency, severity, or duration. And about 40% were completely headache-free. And I'm not sure, because it's not a formal meta-analysis, whether my numbers compare better or worse with Dr. Gairan's, but I think the fact of the matter is if you actually did a statistical analysis, they'd probably be very similar. And those numbers have been consistent when members of the Migraine Surgery Council, of which I'm a founding member, get together and talk about this at the various nerve meetings every year. So I think those are pretty consistent. There's a patient here that has asked, when would you get to the point where RFAs, that's radiofrequency ablation, is no longer effective and excision of the various occipital nerves becomes more likely and necessary. So first of all, let's talk about what radiofrequency ablation is. The term ablation actually literally means to cut out, but in practical terms, it means to destroy. So when you try to ablate something, you try to destroy it. So when surgeons or usually anesthesia pain management physicians are doing a radiofrequency ablation, and there are several gradations of this. Sometimes the ablation is really meant to kill a nerve, and sometimes it's meant to stun a nerve, and that's kind of a lower energy modality known as pulsed radiofrequency ablation. But the idea is that if you have a nerve here, and you have your radiofrequency probe here, using fluoroscopy, which is real-time X-ray, to look for bony landmarks that will guide you near where the nerve is located. So you never actually see the nerve, you see the bone that's supposedly near the nerve, and you know, for example, the nerve is just below that. The idea is that you're going to put your probe essentially right on the nerve and turn on the machine. Now, the radio frequency actually it vibrates very quickly and causes a thermal damage because it vibrates so fast to the nerve. And the points here are that you need to think of it like the flame of a match. If you look at the flame of a match, the hottest flame is the blue flame or white flame that's in the center. The red flame is a little out further than that. And then the yellow flame, which is the least hot or the coolest, is out in the periphery. It's still hot, but it is the coolest. The idea with radiofrequency ablation is that you can get the probe essentially directly on the nerve and turn the machine on, and then either completely destroy it or stun it for a very, very long period of time. Now, one of three things happens with a radiofrequency ablation procedure. One, if you get the probe right on the nerve and you turn it on high enough, you may actually achieve the same result that you'd have with a surgical excision. You'll destroy the nerve in that location, and if you've burned it within a muscle, it may actually be the same as cutting the nerve out and burying it in the muscle. However, because you never actually see the nerve, you're really only approximating, in most cases, where that probe is in relation to the nerve. And so what happens many times is the probe is too far away from the nerve, and then the flame actually never reaches the nerve itself, and so you have no effect. There are cases in which the probe is near the nerve, but not right on it, and so the nerve only gets the least hot yellow flame, and so in that case you'll either have a very short duration of improvement or a very low level of improvement, or both. And sometimes you get close enough but not right on the nerve that you lick the nerve with the red flame, and in that case you may actually get a good result, but you can actually also injure the nerve as well. And if you've injured it just enough or scarred it just enough so that it's painful and causing problems but not enough to kill it completely, many of those patients will have increased pain after surgery, and you'll know that pretty much right away. And it's unfortunately a story that I see a lot. So the answer is, when do you get to the point where RFA is no longer effective? That's done on a per patient and per physician basis, because there are great physicians that can hit the mark almost every time. And if you're getting 6 to 12 months of relief with each of those treatments, then that may be a good management strategy for you. Unfortunately, that's not often the case. All right. We have another person here that says, I often have worse headaches with barometric pressure changes. So I'm the best weather vane, this person says, that anybody knows. I'm better at predicting when a storm's coming than the meteorologist on the news. Why is that? And I hear the same thing with people who have colds. When they have a cold, their headaches gets worse. So there's two reasons why each of these happen, okay? One of the things that happens when you have a storm coming on, whether it's a snowstorm or rainstorm in the summer, is you have a low pressure system. Anybody that's ever watched a meteorologist say that just before it rains knows exactly what I'm talking about. What happens when there's lower pressure in the environment in general is that the blood vessels in the body are allowed to dilate, because the same pressure, same blood pressure, which you presumably have, is now causing the blood vessels to dilate wider with each pulsation, because there's less external pressure keeping them from pulsating very widely. Very often, nerves run adjacent to blood vessels. And so when the barometric pressure is low, such as just before a storm, those blood vessels are going to pump harder against those nerves and traumatize those nerves more significantly than in a regular barometric setting. And therefore, in those cases, your headache may get worse. Now, why do people get worse headaches when it comes to having a cold? The reason for that is because these nerves also, especially in the occipital area, but also in the head and neck area, run adjacent to lymph nodes. Now, typically, we don't operate on patients who are already sick. So if you have a cold or a flu, we would delay your operation until you were better. So when we dissect these nerves in these patients, these lymph nodes are in their normal, very small size, and often you don't see them. But many patients that I've run into who have a history of frequent colds may not actually be sick at the time of surgery, but have a chronically inflamed lymph node, and there have been a number of cases over the years where we've biopsied those. They've always been benign, but those enlarged lymph nodes are always right adjacent to those nerves. So if you are a person who doesn't get chronic sinus infections, for example, but you get one, the lymph nodes in your head and neck region are likely inflamed and are going to be pressing against a nerve, okay? So I've had another question here. How come I've heard so many patients tell me that it takes 3 to 6 months to actually feel better? This is a question that I get asked a lot, and it really relates to not only the number of nerves you're operating on, what it is that you're doing to those nerves, but also how much pressure and the duration of that pressure that has been present on those nerves. So the analogy that I give to many patients is everybody's had the experience where they've fallen asleep on their hand for a little bit of time and they wake up and their fingers are a little bit numb. So they shake their hands out, and within 5 or 10 seconds, all the feeling returns and all is well with the world. And then we've all had the experience probably at some point in our lives where we've fallen asleep on our arms for a little bit longer period of time. And then you wake up and not only are your hands really numb and your fingers really numb, but the wrist and the muscles don't move as well. And that's because those muscles and the nerves that control those muscles have been choked off for a longer period of time and are more stunned, if you will. In that case, as you shake your hand out, eventually blood flow comes back to those muscles and the nerves controlling them, and the wrist moves. And usually in those cases, it may take a minute or longer for sensation to return to the fingers. In addition, because it's taken a longer period of time, those blood vessels to those nerves have been dilated so that they can grab as much blood as possible. And now that the floodgates are open, those nerves are very swollen because they're engorged with blood. And so many times people will have a lot of hyperesthesia in that second scenario when the blood flow comes back. Now, when you're talking about, let's say, an occipital nerve decompression case, many of the patients that I see have had compression for years, sometimes even decades. And it would be like that second scenario where the muscles were a little bit numb or weak, in addition to more significant numbness in the finger, on steroids. So in other words, if you've had compression, and it's severe compression, over any number of nerves for, let's say, 10 years, is it reasonable to expect that within 10 days or even 10 weeks, everything will come back to normal? And the answer is maybe yes, maybe no. If the compression was relatively mild, then you might have a return of sensation as well as decreased pain within a few weeks. But in some cases, and in many of the cases where the compression has been very severe and has been present for many, many years, it's not unreasonable or uncommon for real relief to only begin at sometimes 6 or even 7 months after surgery. And then, of course, the recovery of these nerves doesn't come back in 5 minutes. It's not like a light switch turns on when one day you have pain and the next day it's totally gone. It tends to get better with time, okay? And so in terms of full relief, generally speaking, people will tell you whether you're operating on nerves in the leg, the arm, or the head and neck. You really know what your final results are a year after surgery. Many patients experience significant relief far before that, and it can progress up to a year. So it's not like you're going to have 364 days of the same old discomfort, and then all of a sudden one day you'll feel amazing. You tend to get better, and then better and better with time. Let's see. There is a person here. It says, how successful is decompression surgery on a whiplash injury? And actually, I'm glad you asked that. The one thing that we are working on, several of us who actually publish research in this, is trying to stratify our results based on the mechanism of injury. And so far, we don't have any papers published on that yet. What I can tell you anecdotally from my experience after several hundred cases is that the people who have whiplash injuries actually tend to do the best, as opposed to people who, for example, one day woke up with a headache. There's a couple of reasons for that. One, typically people who have whiplash injuries know they've injured something right away. And so they begin to look for herniated discs and strained muscles and pulled ligaments, etc., right away. And they go to doctors a lot sooner, whereas people who have a headache one day that just doesn't go away often try to treat it for many, many months, especially if it's not that severe, with medications, etc. And sometimes that goes on for years and years. Then they go see neurologists who prolong that process with the various pharmacologic agents. So people who have whiplash injuries tend to see me sooner than people who have spontaneous onset of their headaches. And that means that the degree and duration of the pressure on those nerves actually is relatively less compared to that other group. The other thing that you often find in whiplash injuries, and this begs the question, what is a whiplash injury? I think in most cases, a whiplash injury in people who have chronic pain and no other findings. So you haven't fractured a vertebrae, you haven't strained or torn a muscle, all the imaging studies look okay, and you've failed all the conservative modalities like physical therapy and massage and acupuncture and chiropractic manipulation. Those people actually have traction or stretch injuries on those nerves, because what happens in a whiplash injury is that your neck gets rocked back and forth, and the natural tendency of the body is to tense the muscles so that things don't go completely out of alignment, okay? Well, those nerves that we're all talking about when we talk about occipital neuralgia actually pass through those very muscles that are now super tense. And as those nerves try to glide through that muscle, it's like kinking or stretching a rubber band across the corner of your table. Those nerves will actually get kinked because the muscle is flexed very hard and not nice and loose. And either you have a direct tear and scar of the nerve itself, or sometimes you have a small muscle strain, inflammation, and tearing of the muscle, which then heals with a scar and then compresses the nerve or prevents that nerve from gliding smoothly back and forth. And so that same person who had the whiplash injury a week ago is now moving their head back and forth, but the nerves in the neck are not gliding like they did 2 weeks earlier. And each time they move in a certain direction, they get kinked and they can have pain. All right. Let's see. There's somebody that asked a question here about Lyme disease. So how does Lyme disease affect nerves? Well, there is a known connection between Lyme disease and other tick-borne diseases like Borrelia and babesiosis with nerves. No one knows precisely. There's a lot of theories as to how these viruses affect these nerves. And it is thought, to put it simply, that there is a physiologic problem with the nerves themselves. In other words, it's affecting how the nerve functions, not necessarily the structure of the nerve. So it's more of a chemical, if you will, abnormality or malfunctioning within the nerve, as opposed to a structural problem like a scar within the nerve or a scar external to the nerve but compressing it. In many cases, it's important to try and rule out, if you think there's any chance a person could have Lyme disease or babesiosis, for example, a good, reputable lab should be utilized to test the person for Lyme or babesiosis, etc. And if positive, an infectious disease expert should, or a Lyme literate physician should be able to treat that person accordingly. Now, the one question that always comes up is there such a thing as chronic Lyme disease? And that remains a very controversial issue. Now, I'm not an infectious disease expert, and I'm not a person who treats Lyme disease, so don't take my word for it, but I am repeating to you what one of the head infectious disease physicians, who happens to be a friend of mine, at the local academic medical center at UCSF told me. And apparently, there are a few doctors who actually believe that there is a condition known as chronic Lyme disease, wherein someone had Lyme disease or got infected with Lyme disease many years ago and never knew it, therefore was never treated, and therefore the nerves are malfunctioning chronically because of that. But some physicians, many of them at the academic medical centers, apparently feel that there is no such thing as chronic Lyme disease, and even if you were infected 10 years ago, if you test positive for Lyme with a reputable lab, you can be treated with a course of antibiotics for a few weeks or sometimes a few months. And technically, and from what I'm told, those Lyme titers on repeat testing are negative. And so people should be able to be treated. And if the malfunction of the nerves secondary to the Lyme disease was the cause, then appropriate treatment of the Lyme disease will also help in that condition as well. And most of the time, antibiotic treatment is very well tolerated, so it's certainly a very reasonable thing to try. We have time for one more question. Can you discuss cutting nerves when the nerve is too damaged? So I think what you're trying to ask here is, how do you decide whether a nerve is too damaged and you have to cut it? And there's a couple of things that you use to make that determination. At least for me, I can speak to for myself only, obviously. There are three criteria that I use to decide whether a nerve is too damaged. The first is a nerve should feel like a soft, wet noodle. That's the consistency of a normal, healthy nerve. If the nerve feels tight and firm like a banjo string, there is scar inside the nerve, and you either have to do what's called an internal neurolysis and open that nerve up, separating the various fascicles. Think of it as like the blue wire, the green wire within a larger wire bundle, or the nerve is too damaged, okay? The second criteria is once you decompress that nerve, which is always the first step, and completely decompress it, you should have reconstitution of the blood vessels to that nerve. They're called the vasa nervorum. It's a fancy name. You don't have to memorize that, but you should see blood flow return to that nerve within 5 minutes or so after you decompress it. If you're sitting there decompressing a nerve and watching it and watching it and watching it, and it is still white as a ghost, the blood flow to that nerve downstream is not good, and that nerve is probably not going to ever function normally again. The last criteria is that you have to see what's called a fascicular pattern to the nerve. So if you look at my hand, you can see 4 individual digits, and you can see a little space or black line in between them. Those would be the individual bundles of nerve fibers within the nerve, this one, this one, this one, this one, this one. And the covering of a nerve is transparent. So you should be able to see each of those individual nerve bundles within the nerve. If you don't, that means the covering is thick and scarred, and very likely that nerve is permanently damaged. The one other criteria that comes into play, there's actually several others. If you're questioning whether or not a nerve is viable, maybe the blood flow is okay but not terrific, you think you can see a fascicular pattern although it's not particularly clear, then you have other criteria that also come into play, such as which nerve you're talking about. So for example, in the occipital region, the greater occipital nerve is the biggest nerve. It can take the most damage. Think of it as the brick house in the story of the wolf and the 3 pigs. So it can take the biggest licking and keep on ticking, so to speak. And so that nerve is likely to be able to recover even if you have some questionable findings. It's also the nerve that provides most of the sensation in the back of the neck and in the back of the head. And so you really want to have a higher threshold for cutting that nerve, because if you do, you're going to have a lot of numbness and permanent numbness in the back of the head. The third, or least occipital nerves, those are synonyms, is a nerve that very often you don't miss, because there are other nerves that provide sensation to the same area of skin that the third occipital nerve goes to. Therefore, in the overwhelming majority of cases, if you cut the third occipital nerve, you will actually never notice any permanent numbness. In addition, the third or least occipital nerve is also the thinnest and smallest of the occipital nerves, and is like the straw house in the story of the 3 pigs and the wolf, which means any little bit of damage often damages that nerve permanently. And so if you have a third occipital nerve that's injured and you've got questionable findings, I often will transect that nerve and implant it in the muscle, because the patients won't miss it. And then, of course, there's the issue of sometimes decompression doesn't work because you make the choice or the decision in the operating room that this nerve is going to recover, and not everybody bats 1,000. And so sometimes you're wrong and the nerve malfunctions, or sometimes there's improvement, but it's only 40%, and technically that's not a success. And the patient will come back and say, look, I don't mind the numbness. I'd like to feel a lot better every time I inject this with local anesthetic. I feel 90% better. I want to cut that nerve. So if you have a patient in the operating room who is relatively unhealthy, such that they had to do a lot of things just to get ready for this operation, as opposed to a 24-year-old that could have another operation in a year or two or even 6 months if the first operation isn't as successful as you wanted, that's a person you might decide on cutting the nerve first. That is all the time that we have for today. I see we still have many, many, many more questions that I haven't gotten around to answering. Please make sure you send these questions to our website or through the Peled Migraine Surgery Facebook page or on Instagram or Twitter, whichever platform you're using, and I will certainly try to either touch on them at future Facebook Live events or email you back if you leave us an email or some contact information with an answer if possible. Thank you very much for your time, and we'll hopefully see you again for our next Facebook Live event in 2 to 4 weeks. Have a good day, everybody.